Next up, our last speaker for this session is Dr. Tom Marin from the Tisch Cancer Center at Mount Sinai in New York. Thank you very much. A man after my own heart, talking about the myeloid compartment, so we really look forward to your presentation. Thanks, Tom.
Thank you for having me. This is a great conference, lots of fun data being shown. So I'm going to talk about the myeloid compartment. These are my disclosures. I lead the phase 1 group, hence it's a long list. So as many of you know, when you take if you take a tumor out and you look at it under the microscope, we're kind of myopically focused on turning on T cells, but the vast majority of immune cells are actually myeloid cells, and the most common immune cell within the tumor microenvironment is actually macrophages. And sometimes actually, particularly in early stage setting, there's actually more macrophages than there are tumor cells. And so this has really led to a lot of exploration with our lab to understand how these macrophages are getting in there and where sort of the ontogeny of these. Because when we've been studying them, we realized that very early on, alveolar macrophages are important in setting up the metastatic niche or where the first primary is happening, but they're quickly crowded out. The vast majority of these macrophages are actually monocyte-derived macrophages. And there's this process of emergency myelopoiesis through which some sort of signal, which we are getting into now, from the tumor is really revving up the bone marrow the same way you have emergency myelopoiesis in the setting of infection like COVID. Basically, you have an expansion of your GMP cells very upstream in the myeloid lineage, and you dump a bunch of immature monocytes and granulocytes into the blood that are constantly being recruited to the tumor microenvironment and helping set up and establish and sort of continue this very immunosuppressive tumor immune microenvironment, which is really, we think, one of the biggest barriers to these T cells getting activated. We've done extensive single-cell analysis of untreated human non-small cell lung cancer. We also study a few different murine models, including the KRAS P53 deficient model, which is sort of like a smoking-related lung cancer in mice. And one of the things that we noticed, both in dendritic cells and also here in the monocyte-derived macrophages, was that one of the most prominent transcriptomic pathways of activation was this IL-4 signaling pathway. And it seemed like there was this very strong type 2 signature, similar to what you would expect to see in an allergic condition. So, in medical school, we learn about this sort of black and white type 1, type 2 dichotomy within immunology. Obviously, nothing's that simple. But classically, we think of type 1 immunity is very important for antiviral responses, and it's key to anti-tumor responses. While conversely, type 2 immunity is classically thought of as important for anti-parasitic, anti-helminth responses. In the modern era where we use too much Purell and bleach, we don't get exposed to a lot of parasites, and sort of the cornerstone of the hygiene hypothesis is that lack of use of this type 2 part of your immune system is leading to all the atopic conditions that we're seeing. It's the reason why kids in the US can't have bake sales anymore. And also we think that type 2 immunity in general, because it's sort of the converse to type 1 immunity, is very pro-tumorigenic. And there's a lot of data showing that the stronger type 2 signature you have, the worse outcomes. And this is regardless of immunotherapy usage. This is an older study from pancreatic cancer showing that patients with high levels of the canonical type 2 cytokines like IL-4 and IL-5 have very poor outcomes overall. And this has been shown really across tumor types. So Lisa Cousin's group about 15 years ago published this study. She studies preclinical models of breast cancer, and they had taken out these metastatic breast cancer foci and looked at the T cells, and they saw that all the T cells had a really strong type 2 signature, and she was one of the first ones to sort of disrupt this type 2 signature. So she looked at IL-4 receptor knockouts, or she actually used a neutralizing antibody against IL-4, and she saw a significant decrease in the metastatic potential within her preclinical model. So they went on to use the neutralizing IL-4 antibody, and they combined it with canonical therapies for breast cancer, which are the same as for lung cancer. They actually saw some very nice synergy in these preclinical models. So this begs the question, if they're synergizing with radiation or with taxane therapy, what do they do with immune therapy? So we took our KP model, which is very minimally responsive to PD-L1 blockade, and we used a neutralizing IL-4 antibody, and we saw a significant decrease in the growth potential within this murine model. And when we looked at the KP1 model, which is mildly responsive to PD-L1 blockade, so that's here in pink, you see the tumors are about half the size, knocking IL-4 down, or here we're neutralizing IL-4, you have the same benefit as you do from blocking PD-L1, and you actually seem to have some sort of synergy when you give both these biologic therapies together. So this really begs the question, where is this IL-4 coming from, and what is it acting on? So I'm going to take these in reverse order because that's the way we are going to be able to figure out where it's coming from, is first where is it acting on. And to look at this, we knocked out the IL-4 receptor alpha from a variety of cells within the tumor microenvironment, because initially our analysis from now almost a decade ago really was looking at the tumor itself and also sometimes the draining lymph node. But if we knock the IL-4 receptor out of the tissue-resident macrophages, again, these are the ones being crowded out from the tumor, or the dendritic cells, where we saw a really strong type 2 signature, a really strong IL-4 signaling signature, and even the T cells, we really didn't see any change in the tumor volume. So it really suggests that within the tumor microenvironment, the horse is already out of the barn, and IL-4 is not really acting there. And we aren't really detecting appreciable levels of IL-4 in the tumor microenvironment, at least in lung cancer. So that led us to the hypothesis that maybe something's happening upstream. So we're seeing this transcriptomic signature downstream of IL-4 receptor. Maybe that IL-4 receptor is being exposed to IL-4 upstream. And that's exactly what we were able to show. So we used the MS4A3 Cree model. This was developed by Florent Genoux at Institut Gustave Roussy. And so here you can knock out a receptor very early on in myelopoiesis. So that's at the GMP stage before differentiation to monocyte or granulocyte lineages. And if you knock out the IL-4 receptor alpha very early on, you see a decrease in the growth potential of these tumors. But if you look just downstream at the monocyte or granulocyte progenitors, you don't really see any impact. So that really suggests that IL-4 is acting within the bone marrow, and it's imprinting very early on in myelopoiesis, really upstream of the subsequent formation of these quote-unquote MDSC populations, the monocytic and granulocytic progenitors that are being revved up during emergency myelopoiesis and tracking to the tumors. So it seems like something's happening very early on in myelopoiesis, somewhere in the bone marrow compartment, but where is the IL-4 coming from in the bone marrow? We think of it classically as sort of a cytokine in response to certain antigens, allergic antigens, what have you. So we used a GFP reporter mouse where we initially looked at sort of the canonical cells that you would think IL-4 would be coming from, so CD4 T cells, B cells, ILC2s. We saw zero IL-4 in these cell types within the bone marrow, but the type 2 granulocytes were actually making tons of IL-4, both the eosinophils and basophils. And eosinophils are always a little confusing. I feel like for every paper I read about eosinophilia being a good prognosticator as far as response to immunotherapy, there's one that says it's bad. Also, we see a lot of eosinophils regularly in the actual tumor itself, but we see zero basophils. So we focused on basophils in particular because when we looked at the bone marrow of tumor-bearing mice, we haven't been able to look at humans yet because we don't do a lot of bone marrow biopsies on our lung cancer patients, but at least in these mice, we saw a very strong co-localization between the basophils and these GMP cells, these early stem cells. And this is something that we don't see when mice don't have tumors. And so it seems like there's something in the tumorigenic milieu that's driving this co-localization and crosstalk. So this is our sort of initial working hypothesis, is that these type 2 granulocytes are pumping out IL-4. They're leading to expansion of these myeloid progenitors that are then trafficking to the tumor and setting up the immune suppressive microenvironment. And then the last question about the IL-4 is, why are the basophils even doing this in the first place? So I mentioned that we're only seeing this in the tumor-bearing mice. And indeed, when you take basophils and you incubate them with either tumor-conditioned media or just control media, you see that they only make IL-4 in the setting of some sort of tumor-drive factor. So we ground up some of these tumor-bearing lungs and compared them to normal lungs, and we saw these 8 cytokines and chemokines in particular that were significantly upregulated and being sort of secreted by tumor-bearing lungs in the mice. And of these 8, actually 6 of them I was able to identify in serum from patients of mine with early-stage lung cancer. So it seems like there is some sort of overlap here. We were hoping that one of these cytokines was going to be a magic bullet and we can neutralize it and cure cancer, but unfortunately, when we looked at each individual one, other than maybe IL-18, none of them really were strong inducers of IL-4 by the basophils. It was really sort of this cocktail of all this collection of cytokines. I call it the Gestalt approach, that you need all of them acting on those bone marrow basophils in order to upregulate IL-4 and really lead to this whole emergency myelopoiesis conundrum. So there's sort of this cyclical, downward spiral where tumors are making these cytokines, they're polarizing and hijacking your bone marrow, leading to production of these immature monocytes that are trafficking back to the tumor and allowing further growth and immune evasion. So this is great data. I'm a human doctor, so I wanted to see how we could actually translate this. And so fortunately in human beings, we have an IL-4 neutralizing antibody. So this is, or it's not a neutralizing antibody, it actually blocks the receptor. So dupilumab binds to IL-4 receptor alpha. And so it not only blocks IL-4 signaling, it also blocks IL-13 signaling, which is another type 2 cytokine. And this is a very safe drug. It's FDA approved for dozens of things, all different sorts of atopic conditions. It's even given to children with bad asthma. So we were comfortable bringing it into some of our patients. And initially what we did was we started this study in our patients with relapsed refractory non-small cell lung cancer that was progressing on immunotherapy. All we did was continue the immune therapy that had obviously stopped working. And we were looking to see if we could rescue the response by giving 3 injections of dupilumab. And here we did a bunch of biopsies before and on treatment to try to study if we were seeing the same sort of things, as well as blood collections. And nicely, in the first 6 patients, we actually saw one of the patients who had rapidly progressive disease. This was a patient progressing on immune therapy. They'd had chemoradiation and were on consolidated durvalumab. They saw rapid progression of their disease, not only in the bed that had been irradiated, but they also had tumors in the back. And after just 3 doses, they basically were in near remission. I think a lot of the findings on day 56 were inflammatory. This patient then just continued immune therapy, and he's now more than 2 years out from this initial therapy. And we've now completed this study. We're going to be reporting it out this fall, but we're seeing some additional nice responses to this sort of rescue approach. And looking at the biopsies, we actually are seeing very similar results to what we see in mice, which it's pretty rare that happens, unfortunately. So we are seeing an induction of CD8 cells. We're even seeing some patients who have a real impressive influx of DCs, which we were surprised to see, and then also the formation of these tertiary lymphoid structures. We're also in the blood seeing a progressive decrease in the sort of inflammatory monocytes that are being made by this emergency myelopoiesis. And we're seeing cytokine signatures that really suggest, very early induction of type 1 immunity and even late induction of cytokines like IL-2, 7, and 15 that are really important for supporting anti-tumor T cell responses. So we think that we're acting on the myeloid cells, but then really releasing the T cell responsiveness. So now we've started this study. This is a neoadjuvant study. We're actually hopefully going to be opening this with some colleagues here in Montreal as well, just giving a single dose and then 15 days later cutting the tumor out. And not to highlight Canada too much, but I love collaborating with Canadians, it turns out. The Ontario group has this neoadjuvant program, which is amazing, that was started by Angel and Melanie. They work primarily in breast cancer. They have some trials in lung cancer and bladder cancer, but I showed them our study, and they opened and closed this study in a matter of months. It really blew my mind. Here they gave patients either just PD-1 or PD-1 with dupilumab for just 2 weeks prior to taking them to the operating room. So we're in the process actually of getting some of the tissue sent down from Toronto to look at some of the myeloid signatures there. And so just sort of in summary, we have this factor coming from the tumors that's polarizing the bone marrow. We think that we can disrupt this using dupilumab. However, we're also identifying a variety of other cytokines that are upregulated and very important in this sort of, like I said, a downward spiral that's really allowing the tumor to grow. I'd say one thing that we have a paper coming out hopefully in a few months that I can show you more data then, but we think that along with blocking IL-4, we really should be blocking the inflammasome, not just IL-1 beta, which has been extensively discussed, but IL-1 alpha appears to be even more important than IL-1 beta. So we actually just opened this sort of follow-up study where we're giving the exact same cocktail I just showed you, trying to cut off this emergency myelopoiesis at 2 different points. So along with giving dupilumab, we're going to be giving a month of anakinra, which is the IL-1 receptor blocking drug, so you cut off both alpha and beta. And I'll skip over this because I think I'm out of time. Obviously, thank you to all the patients who trust us and their families that spend way too much time with us, and Miriam Murad and her whole group who are my partners in crime.
Hi, great data you presented. I have a question on the decision to use Dupi and not to use a biomarker and select patients with a biomarker who would get Dupi versus wouldn't, the same way we do in airways disease. Can you comment on that?
So that's a great question. We don't have a biomarker. So in airway diseases, you can use eosinophilia as one of the reasons why, how to decide which COPD patients to give Dupixent to, for instance. We don't know for sure if there is a lot more IL-4 in the patients, even those lung cancer patients that have eosinophilia at baseline. It's very difficult to actually measure IL-4 in the blood of these patients. So far, I'll tell you, one of the goals of the first study was to see if we could identify a biomarker. From the first 6 patients, one of the things we did see is that even though it's very difficult to detect IL-4 in the blood of these patients, in the patients that get the receptor blockade, you actually see a spike in IL-4 in the blood, similar to what you see with IL-6 receptor blockade. So that, it almost seems like those patients probably do have higher levels of IL-4. We can't detect it with the O-link analysis we're doing until we block the receptor and you sort of block the sink, and then you're actually able to detect it. So we might, eventually be able to validate that or have a more sensitive assay specifically for IL-4 or just more of a type 2 immune milieu, but we haven't proven that yet. It's the holy grail.
We have one question over here.
Thank you for this fantastic talk. I was wondering to which extent you think that some of the IL-4 and myeloid microenvironment background may be potentially driven by the TP53 and KRAS mutation background, and whether you have seen differences in patients responding depending on which mutations they actually have in their tumors.
That's a great question. So when we were initially looking for the IL-4, when we found the IL-4 signature in the single cell analysis, and we see it both in dendritic cells and in the monocyte-derived macrophages, we actually see it regardless of etiology and mutational background. So we even see this in patients who have oncogene-driven cancers. We see it in EGFR patients. And so it's not just, we always obviously are looking for immune targets more in the smokers, but it's not just there. So interestingly, when you're looking at those myeloid signatures, you see it both in KRAS, P53 smokers, and also in EGFR ALK patients that we've looked at so far. It was very counterintuitive. I was surprised to see that it's a similar immune microenvironment. And we also see the same sort of immune makeup of these myeloid cells across all solid tumors that we've looked at. So it's not just lung cancer. We're seeing it in liver cancer and colon cancer and bladder cancer and breast cancer and in prostate cancer. Those are the 6 tumors that we've looked at so far. But it seems like these are sort of shared immune programs that lead to immune evasion across cancer.
All right. Oh, Normand, you have a question?
I might have missed part of your talk because I was busy with Twitter getting all of you on the social media, but from what I understood, do you feel that we can eventually dissociate anti-tumor effects with anti-inflammatory immune adverse events from IO? Are those 2 different processes, and can those be dissociated with treatment?
It's a good question. So it sort of goes to the heart of the concept of inflammation. People always wanted to cause inflammation in a tumor. Inflammation is not inherently good because we know that neutrophils and these macrophage accumulations is bad. The crosstalk, we don't have a large enough data set yet to look and see if certain IRAEs are characterized by certain immune evasion at the same time. Classically, we always think that an IRAE portends a better response, but we know that's a mixed bag of data. I will tell you that I was just meeting with one of our dermatologists yesterday who we send a lot of our dermatitis refractory patients to, and they're actually treating those patients with dupilumab, and we helped develop dupilumab at Sinai across indications, and we actually have data from patients that have been treated for at least 6 years on dupilumab having a significantly lower rate of all solid tumors. And so it does seem that there is, you might see some sort of crosstalk between the treatments that we're giving for IRAEs. The underlying pathology of IRAEs, I think it's very difficult. It's probably a mixed bag of things, and I don't know if we'll ever find sort of a specific overlapping signal between those 2.
All right. Thank you for that. You guys can continue to chat for another 10 minutes until 2:45. Thank you. It's really good. And then we'll start with the next section. So 10 minutes back at 2:45. Thank you very much.